and also the response to ADs, it appears slowly. So this fact may increase the risk of treatment-resistant depression or difficult to treat depression because we lose time and the patient is suffering. So that's why I think that we need more effective or more alternatives also to the first line treatment methods when we treat depression, just to prevent the patients and to treat our patients more efficiently and to prevent the difficult to treat or treatment resistant depression. So I think that we are here in the question of having alternative treatment methods to start the depression treatment, and also when we have more tools to start with. So then we should also focus the clinical picture of the present patient that we are treating, and so it leads. I think it's at least in my work, I feel that when I have more options, so I just have to start to think more precise. Why do I choose this treatment method to this patient? So I have to focus more on the clinical picture, and I think that it increases the quality of my work, because I have to be sure, or at least go a little further than a qualified guess, which we usually do with medication. And then there is also option when you have more tools, so then you can combine the treatment methods, like to speed up the response, and when you fight against the time with your depressive patient. So I think that the TDCS is also a possibility to prevent, to kind of fight in the battle of fighting the treatment-resistant depression. So you can focus the initiation of the depression treatment, and then to prevent the treatment-resistant depression. So only start also to well tolerated treatment methods, and also to switch to another if the patient is not tolerate the medication. So then you may switch to TDCS or boost the antidepressant effect with TDCS, kind of adding on TDCS. And also then you come to the question that there is also a synergy effect when you treat the patient with psychotherapy, medication, and TDCS. So then you have kind of a synergic treatment method for that patient. So when you have more options or tools, so you must focus more on the clinical picture, and also those response predictors, and then consequently it leads to a better and more individually planned treatments for individual patients. I think, at least in my work, I think when I have had these tools to operate with, so I think that the quality of my work is has been raised. I speak a little about transcranial magnetic stimulation. I don't know if you use it in Mexico, but in Finland, our national current care guidelines for depression, they say that TMS is a safe and well tolerated treatment method for depression, and its effectiveness is around in the level of antidepressant, as we say about TDCS also. But as you see, when a patient goes to RTMS, so you have to take a MRI from brain, and then you need personnel and equipment, and healthcare resources to treat your patients, and it's not so every patient is not in the same position, because we are not in Finland. We don't have this RTMS machine in Lapland or every area in Finland, and also it's kind of expensive treatment method, but it's very effective also in treatment-resistant depression. So when I see this article from Voigt and Carpenter, who said that they concluded when they studied the cost effectiveness of RTMS, and they studied that and concluded that RTMS should be introduced to a patient after first antidepressant failure. So then I started to think that should we treat our patients earlier with TDCS, so not to come to a situation that antidepressant is not working and time is going, and then I should already think RTMS, which is quite heavy treatment method, and also it's not easy to reach to every patient, and then we need MRI, and it's more expensive. So that's something that I came in mind that we should also, for this reason, cost effectiveness, to start earlier with TDCS or with combining treatment methods. So TDCS it's 1 year now been in our national guidelines for depression, and our guidelines say that it's a novel brain stimulation method, and its effectiveness is around the level of antidepressant, so a little bit lower than RTMS. Review of evidence is level B nowadays, but I think that we are gaining the evidence all the time now, and the knowledge is building up, and I think it's easy and cheap to use and can be used at home. We have this recent article in International Journal of Neuropsychopharmacology, where TDCS is graded to a level A for treatment of MDD, and I think that in Finland we are kind of moving towards this level A nowadays, when we have more experience of the treatment method. So then it's easy because it's kind of a parallel to RTMS, at least in our guidelines. Also, it is also a question of guiding the right patients to TDCS and the right patients to RTMS, also, even if you think that they are parallel. So then I can move to TDCS in clinical practice. I have some review articles here also to present, and I think that the effect, we all know that the effect of TDCS is correlating with the effect of RTMS, and the experience is growing now. The efficacy is around the same of medication, and it's a cheap neuromodulation treatment, at least compared to RTMS, and it's very easy to administer at home. But when you have a patient who has a very severe depression or heavy treatment-resistant depression, so that impairs the likelihood of response to TDCS. So that's why I think it's wise to start early with TDCS with those patients who cannot tolerate medication or need some boosting with their medication. So moderate degree of treatment resistance, then it's better as response. at least to all all treatment methods, but also to TDCS. And I think it's a method in treatment initiation in depressive patients. Here is Australian and New Zealand colleague of psychiatrists who say, I think that this is very important, what they say, that when you prescribe TDCS, so it should be after careful evaluation by a psychiatrist and under supervision of psychiatric. And this is the case that I see that you have to focus on the clinical picture of the present patient so that you can choose the best treatment method for just that patient. And also they recommend that in TDCS treatment, we should have formal policies and procedures like in other neuromodulation treatments like ECT and RTMS and ketamine treatment, also to prescription and to use, and also train our clinicians involved this treatment method, and also to monitor the outcomes like we do in other neuromodulation therapies like in ECT and RTMS, and also then gain knowledge about the clinical indications, which are the patients that are benefiting most TDCS. They also say that there is a little safety data of pregnant women and also to children or adolescents. And I have I have treated some, at least one pregnant woman and also after childbirth, but I don't know, maybe in Estonia there is some study about TDCS in pregnant women, and also in other countries maybe some studies, but that's not in my expertise. So here's my conclusion after working about 5-6 years with TDCS, and these opinions, these are based on my own clinical experience. So I think that TDCS, it appears to have no serious acute adverse effects, and it could therefore be used at lower threshold in the early stages of depression treatment. It's one option to start with among psychotherapy and medication. But I think we should be careful with this treatment method and to deliver it with qualified protocols so that we evaluate the patients carefully when prescribing TDCS, and also start to try to focus the clinical picture of patients so that we get the knowledge of facts that predict the response, and we kind of learn what kind of patients benefit most TDCS, and also to monitor the patient. Don't just leave them with the device and say bye-bye and do well. So monitor the patients during the treatment, and also think about the what happens after the treatment. So how we prevent the early relapse or relapse at all. And just like we do in other neuromodulation treatment, we have protocols, and we use screening instruments, psychiatric rating scales. I use mainly BDI and MADRS, and these are familiar here in Finland. I don't know if you have HAMD or some other instruments, but I think it's a good to have these screening instruments that you can monitor the patients after or during the treatment. And about patients who have mild, moderate, maybe severe depression, not complicated depression. When patients who have first medication, they have only partial response. So then it's an option to add on treatment, TDCS. And also patients who have tolerability problems with medication, So maybe you can switch from medication to TDCS or add on TDCS so that you boost the ongoing antidepressant. In my clinical experience, I can say that the patients who have comorbid anxiety, those patients kind of benefit quite well this treatment method. It's my own clinical experience, but in the second week of treatment, they usually report that the anxiety is slowly vanishing. And when you have to speed up the response, so then you can add TDCS, kind of response to psychotherapy or response to medication. And of course, if the patient wishes to try TDCS, so then evaluating carefully the clinical picture and the patient's degree of depression. So then it's also good reason to start. These are the slides that you don't have translated, but I was asked to tell about adverse effects or side effects, what patients report. And here is the one. It's the irritation of the skin under the response, so under the electrodes. So no patient has reported any other side effects. So it's quite well tolerated treatment method. So and this is also a slide I made just today, and what to tell to the patient about TDCS when I introduce or recommend TDCS. So I usually say that it's a mild neuromodulation method, and then I tell what is neuromodulation, that we try to modulate the neurons to kind of work better. I tell that it's a treatment that you can do at home, and the effect is based on that we stimulate the brain's cortical areas in which the metabolisms may be imbalanced due the present depression. I also tell that the TDCS is safe and it has no marked side effects, and that its effect is around medications effect. And also I tell that when you do something during the treatment, so you think or solve some problems or read or exercise, so it works better. So when your kind of cortical areas are active, so the treatment is working better. What the patients ask, usually they don't have many questions. Usually they ask about the effect, how effective the treatment method is, or do it have some severe side effects. These are the questions mostly asked. But I also, when I introduce or recommend the treatment, so I give a leaflet to the patient to read at home, and also I guide the patient to a nurse who checks the exclusion criteria, and there is also an opportunity to ask some questions to the nurse if you have read the leaflet at home. And I think it's also important that the patient feels that there is some person back up during the treatment period. So I tell that you can contact me or the nurse, and you can reach us if there should be any problems with the device or the treatment at home. So the patients are so they feel that there is someone during the treatment to reach out if you have some problems. So it's calming. So here is the kind of step-by-step what we do in my private clinic. So I'm a psychiatrist or occupational health doctor or some doctor thinks that TDCS might be good to this patient and prescribes the treatment and evaluates the patient depression degree and also medication. And then the patient is guided to make a reservation to a nurse. And then there is the initial visit with a nurse. So nurse guides use the device and also gives the first treatment in his appointment. And the patient also feels PDI, and the nurse maybe feels much if it's not done in the psychiatrist appointment. And then usually nurse is giving phone calls to the patient once a week, so how you are managing. And then there is after 4 weeks, and then there is an appointment with the nurse, and also or appointment to a psychiatrist, and also discussion with the psychiatrist if the patient is seeing the nurse. And then psychiatrist is deciding if should go to the continuation treatment or to stop the treatment if there is no response. And the psychiatrist is monitoring the treatment and also the continuation treatment if they decide to go to continuation, and then also the maintenance if the patient is going further with the treatment. And so the psychiatrist is in the background all the time. So this is the protocol more simpler. So you see that the patient is using the device at home, and nurse is calling, and also we do those PDI and MADRS evaluations, and then think about the maintenance and continuation all the time, so that after the treatment is stopped, so how we prevent the early relapse. So it's important not to lose the patient, kind of stay in contact with the patient when he's using the device at home, and following up the treatment course, and then also there is a chance to change the plan if needed to some other neuromodulation therapy if the patient is not benefiting, or medication. So it's important to be in the background. I also wanted to introduce to you some of my thoughts about continuation and maintenance. And if you have been dealing with ECT, so you are, I think you are familiar with continuation or maintenance ECT protocols, and that's the one thing that we can learn to other neuromodulation therapies like RTMS and TDCS. So how we stop the treatments and how we go on further to preventing the relapses. Because if we treat our patients with antidepressant, so our guidelines say that we should continue for 6 months to prevent relapses, and maintenance considered after 3 lifetime episodes. And also after any neuromodulation treatment, it is important to plan the relapse prevention already when you give the acute treatment. So this is our protocol of continuation and maintenance. If the patient is having a response, or if he's going to remission with TDCS, so it's not wise to stop immediately afterwards, because then there could be early relapse. So I have been giving the patients treatment 3 times a week or 2 times a week during first or second month after response or remission, and on 3rd month then slowly tapering the treatment to once a week or twice a week. Usually my patient, they use the device maybe 2 to 4 months after acute treatment if they get response or remission. 6 months it's quite long time, but I had a couple of patients who had the tapering protocol to 6 months, but it's only a couple of patients. So usually they can quit slowly the treatment in 2 to 4 months. And then there is also an issue that if our patient get ECT or RTMS, and if they are very prone to relapse, so then the continuation and maintenance is recommended using ECT or RTMS, but the patients need to go to a clinical center that delivers the treatment, ECT or RTMS, and maybe TDCS could be advantage due to its portability, at least to some patients who need continuation and maintenance ECT or RTMS. Here is an article about preventing relapse, and twice a week is quite beneficial. I think this is future, and I don't know if we have, at least I haven't got any kind of scientific research in this field. I don't know if Mika has some, but in our some of our clinics, they use this TDCS after RTMS or after ECT as a maintenance to preventing relapses. So here is my take-home message to you about my presentation. I will give you also some patient examples after my presentation if you would like to share my patients with me. But this is my kind of a take-home message that I want to say according to my clinical experience. So I think that the TDCS it's a good opinion to start. It can help to accelerate the response to medication or to those patients who cannot tolerate the medication. So it may be beneficial to patients with comorbid anxiety. At least in my patients, I have seen that the anxiety is vanishing in the second week of the treatment. I think it could be beneficial more to younger patients than older patients. Like you know that the ECT is more effective to elderly patients, and I think that RTMS and TDCS they are more likely to benefit younger patients because it's an issue of plasticity of the brain. You can use TDCS as an add-on. You can add it to psychotherapy or medication or do both. In my opinion, and based on my clinical experience, it's patients adopt TDCS very well to use at home. It's easy to conduct, but it's important that you have kind of weekly phone calls or kind of be in touch with the patient during the acute treatment. And also it's important to evaluate and follow up the patients by using rating scale so that you see how the treatment is how effective is or is it benefiting the patient? Should you change the plan or how is it going? Kind of opinion of the patient, like BDI, or the opinion of the clinician, like MADRS. And then also the continuation and maintenance, it seems to be beneficial to maintain the response after acute TDCS. And also it's more efficient, the continuation, if you plan it individually, like hearing what the patient is saying and also following up how the follow-up period is going on. And also TDCS could be used after another neuromodulation therapy along with medication to prevent the relapse. So this is my take-home message. Would you like to ask something now, or would you like to share my patient experience with me now, or should you have any questions?
We have a little bit of questions, but
Okay.
we can talk about your patients, and in the end, we can ask you the questions. Is it okay
Okay.
for you?
Yep.
Yes.
That's okay for me.
Okay.
Yeah. So here is a young woman who had a recurrent depression since she was 15 years old. She also had eating problems in the adulthood and anxiety and adolescent eating problems and also anxiety, merely social anxiety or social difficulties. She only had partial response to antidepressant. She had adverse effects, tolerability problems, and also she had gone 3 years psychotherapy already. And she was continuing sertraline 50 milligrams. She could not tolerate anymore, and the other medications also not tolerable. So we introduced TDCS, and I prescribed TDCS for her, and she did it for 3 weeks, and she told that the anxiety and the hopelessness it relieved, and she told that it kind of vanished or just went away, and then she started to continue of working and started to study later, and she had maintenance for 2 months. I think she had I think she did TDCS first 3 times a week, and then 2 times a week, and then once a week, and then she stopped. And we didn't change the medication because she had so much bad experiences about the other medication. So she tolerated the sertraline 50 milligrams, and that was that. That's we only boosted the sertraline medication with TDCS, and I think that TDCS helped also the anxiety because the patient felt like that in the second week. So then there was also a case of combining treatments. It was older man, 48 years old, and he got a shoulder operation and couldn't work and had pain also. And then there was his first lifetime depression episode, and venlafaxine was started because of the pain. Also tried citalopram and mirtazapine, and no response at all, only tolerability problems. He got TDCS, home-based TDCS, for 3 weeks, and he got response after 2 months. He continued. I think he continued after 3 weeks. We started another 3 weeks treatment, and he got a response. And also after 2 months maintenance remission. It kind of this was a patient that it was not very quick, the response, and I don't know, maybe it was due to his age or something like that, but he got response and then slowly went to remission, and he started to plan part-time work and kind of saw more options in his life than after the shoulder operation, when he was in pain and also kind of losing his working capability. He had no medication during TDCS, but we started vortioxetine to prevent relapse during maintenance TDCS, and he accepted that, and he also went to psychotherapy after the treatment. Here is an example about boosting treatment response. It was 30 years old female who had her first child, and her child was 3 months old when there was a huge relapse of depression and anxiety. She had anxiety disorder, anorexia in adolescence, and also she was very demanding to herself and had been already in psychotherapy. And she had a recurrent episode of anxiety, depression, and also OCD symptoms worst after her childbirth. It was quite heavy, the depression, and the relapse was, and she had very severe anxiety, suicidality, and couldn't spend any time alone with the baby. And the medications were started quickly, sertraline, oxazepam, but she was so extremely panicked that we started already at the initiation of the medication. We started also TDCS, and it started to show response on the second week. And I think it helped the patient also use the medication, because the anxiety was so huge. And she got 15 sessions TDCS, and got I think she went to remission, or at least she got very good response. And then there was maintenance and slowly tapering the treatment in 4 months, and she was very satisfied, and this went well. This is my happy patient. She was a 50-year-old female who had worked previously as an engineer, and had a recurrent depression, and tolerated medications, kind of massive amounts, citalopram and bupropion, and she had made her own TDCS device, which she introduced to me, because she had learned from internet about TDCS, and we didn't have in our outpatient clinic TDCS then. And but she was very clever, and did her own TDCS device at home, and she made some salt jelly in her kitchen and used baby sponge as an electrodes. And whenever she was feeling sad and could not tolerate her mood or her children or something in her life, she took a treatment. And she could put the device on when she was having her daily nap, and she felt that the treatment raised her mood significantly. Sometimes she took 2 sessions a day, and she said that she couldn't manage her life without homemade TDCS. But this was a patient that we discussed about the length of the TDCS sessions and the mechanism of the treatment, and that the neurons should also have some resting time, that you cannot stimulate all day long your brain. And here is a patient who was a 50-year-old man, and he had a very severe depression and had suffered from recurrent depression since early adulthood, and she had some response, and also went to remission with medications earlier. But he said that medication did not benefit him anymore, even if they had worked before. And then when I saw this patient, I think that he had quite severe situation then, and he had a treatment-resistant depression, because he was not benefiting at all any medication, and also he wouldn't like to start new medication, because he had so bad thoughts about medication. And I guided the patient to RTMS, and he got a very good response. But the maintenance was a problem, because when they stopped RTMS, she was kind of moving towards depression again. And we started quickly TDCS when the depression kind of raised kind of was coming, but it didn't prevent the relapse. He relapsed and he got a new acute RTMS, and it worked well again. And at that time, when this patient had very much experience about medications, also psychotherapy, and also RTMS, and then also about TDCS. So he said that he could compare the treatment methods, and he told that the response from TDCS, it was actually quite good, not in the level of RTMS, but close. So it's kind of a statement that we can read from our guidelines and from the data of the RTMS and TDCS, so that it's quite near the response to TDCS and to RTMS. So he started the maintenance with RTMS, but when we added TDCS to RTMS maintenance, and the plan is to move him slowly to only TDCS maintenance in the future, and he is very pleased that because he said that it's very important that you can take the treatment at home, and also that you can trust that there is some other treatment methods to antidepressants to maintain the remission or response. So here was my patients and my presentation. I hope you enjoyed, and now you can ask some questions and also give your experiences if you have some experiences with TDCS. But thank you. It's kiitos in Finnish.
Okay, thank you, Kaija. Let's start with the questions. The first one is, do you recommend it on substance abuse? Do you have any experience on that?
No, I don't have any experience. I think that there is some studies about TDCS and substance abuse, but I don't use it to those patients, and at least I really don't treat much substance abuse patients. But I think that it's I don't have any good experience about these patients.
Okay. Next question is, well, you talk about that after the Q&A, but I want to ask you again, the average time about in patients. For example, you mentioned anxiety, but what about depression?
I'm sorry, it was I didn't hear the question because the internet was some.
Yes, I think it had a little bit of connection problem about the average time in response in patients.
Average time. I think there is some response showing at least when you on the second week. I usually see something, and that's also a predicts good response when you see something in the second week. But it's not necessarily because there was this older guy who was 48 years old, and he got response after, I think it was 6 weeks, and went remission in 2 months. So, but it's I think if I should say something, I say that it's the second or third week that the response is coming. Usually in the first week, patients say that they are sleeping better.
Okay.
That's the first what they tell.
Also, you mentioned about young patients. At which age do you recommend to start these methods?
I recommend it to adult patients, but I know that in Finland there are some studies, or at least some doctors have treated patients around 10 years, 7 years, but I don't I don't treat children, and I cannot recommend it because in Finland it's recommended to adult depression. But I think if you have a patient 18 years old or something like that, it's okay. I could prescribe it to 18 years old, because in Finland we think that 18 years old is an adult.
Okay. Another question is, what do you consider as a main factor for non-response patients? The ones that don't respond to the treatment of TDCS or TMS.
So what is the main factor that they don't respond? Or I really
yes,
did
to the treatment.
So what is the reason?
Yes. What is the main factor? Do you think is the problem with patients for not responding to TDCS treatment or to TMS treatments?
What is the main factor? I think that the depression is too severe, or then there is some comorbidities that it's not only a problem of depression. It may be some other problems. So maybe you should think about the diagnosis again, and then if it's very severe, then you should think about ECT. But I think that the TDCS is for mild or moderate, and then you go to a heavier depression, then you can consider RTMS, and then more heavier depression you have, then you should consider ECT, and along is the antidepressant medication to patients. But I don't know if I answered the question right, but maybe it's the problem of diagnosis, or to have to focus on the diagnosis if the patient is not responding.
Okay. Another question, thank you, is in any of the anorexia cases, was the body dysmorphic disorder present? And if so, was there any improvement in the patient's perception after treatment?
No, she had no anorexia anymore. If you talk about my patient, and she was recovered from anorexia. It was kind of a more anxiety that she had at that time, and okay. I don't have any experience of body dysmorphic disorder with TDCS. To some patients who have had also OCD, I have tried with TDCS, but I think that it works well to depression, not to OCD.
Okay, thank you. Well, do you have any experience on using it on patients with pacemakers?
No, I don't have. I don't know if Mika can answer. Is it exclusion criteria if the patient has a pacemaker? I don't have. My patients, they don't have pacemakers. At least I haven't faced this problem. But I think it's a. Is it exclusion criteria?
Yes, pacemakers are typically contraindicated for TDCS treatments. There is some initial evidence that it could be safe, but it's still not conclusive, so we have decided not to risk it.
Okay.
Yeah, that's why.
Okay, another question is, do you have any experience on patients with pain-related depression?
Actually, not in TDCS. I don't have. This was the one patient, but which was in my my examples, but not much. But there is also indication to pain with TDCS, but I haven't treated pain patients or patients who have depression and pain. So I don't have very much experience in those patients.
I think we're on time. So thank you for being with us today. Just a little Spanish advice before. Recuerden que tenemos la beca, ya está online el curso de capacitación de TDCS con la Sociedad Mexicana de Neuromodulación. En este momento les paso el link y recuerden que ya incluye una beca en la compra del dispositivo con nosotros, Soma. Esta beca está incluida, ya pueden acceder de manera gratuita al curso. Okay, Kaija, well, thank you again. Take care.
Yeah, you too.
Mika, thank you as well. Todos, muchísimas gracias por acompañarnos. Llegamos al tiempo y cuídense mucho. Estamos invitándolos a más webinars con nosotros. Muchísimas gracias por acompañarnos.
Bye.
Mika, Kaija, goodbye.
Goodbye.
Bye.